Cleveland and Mayo Clinic. He's recently doing his researches, so he'll be helping you find the best journals for the publication. Is that right? Hello.
Sir, thanks so
Yes,
much.
thank you.
Yeah.
Yes, thank you.
Okay. So let's start our today's lecture. So today we'll be starting with lumbosacral plexus, right? So we are already done with the upper limb. Okay, let me just share my screen. Can you guys just see my screen? Hello.
Yes, sir.
Okay, perfect, right? So we discussed brachial plexus, if you guys remember, right? And we know what does the plexus mean. We discussed plexus is basically, a bunch of or a network of nerves, right, coming out. So as the name indicates, so we have lumbar plexus, right? So what do we mean by lumbar plexus? So these are the plexus or collection of spinal nerves coming out from your lumbar region. Simple, that are lumbar plexus. What's the main goal and main idea of these plexus? They're going to supply again some muscles and sensory innervation, as we discussed in brachial plexus. Brachial plexus were for your hand, right? So here you guys can see that these are your lumbar plexus. It starts here from T12 and at L5, and all of these nerves will be discussing. Like you have your iliohypogastric nerve, you have your genitofemoral nerve, lateral femoral cutaneous. We'll be discussing each one in detail, like your iliopsoas and femoral nerve, right? Okay. Then we also have our sacral plexus as well. Like here you guys can see this. If this is our lumbar plexus, so we have our sacral plexus as well. Again, the definition implies to sacral plexus as well. What are sacral plexus? Collection or network of spinal nerves coming out from your sacral region, right? But we'll be referring like together, we'll be just calling them as lumbosacral plexus, right? So like basically the lumbar plexus and sacral plexus, they have different jobs, but here we'll be just discussing them, all of them, like in combination. I'll be just using a lumbosacral for that, right? So again, here you guys can see these are your lumbosacral plexus. And what's the goal of them? You already know, supplying your muscles, your motor activity, as well as sensory innervation, right? So you guys can see here, we'll be discussing sciatic nerve, we'll be discussing like gluteal nerve, which are basically coming from the sacral plexus, right? So the first one which we are going to discuss in lumbosacral plexus is, yes, your iliohypogastric nerve. Like you guys already see it here. Where is our iliohypogastric nerve? This, right? Iliohypogastric nerve coming out of your lumbar plexus, right? So you guys can see it comes from T12 and L1. You guys can see here. Is it right? Hello?
Yes, sir.
Okay, so it comes out from like which spinal root? T12 and L1. What's the function? What's the main goal of iliohypogastric? So it have both motor and sensory functions, right? So remember, for the motor function, it would supply two muscles. Which muscles? Your transverse abdominis muscle and internal oblique. So you guys can see it here. This is your internal oblique muscle, and this entire muscle is your transversus abdominis, right? So the motor innervation to these abdominal muscle is basically supplied by iliohypogastric nerve, right? So this is basically the motor innervation of your iliohypogastric. But what about sensory? So the sensory innervation, it supply the hypogastrium. As the name indicate, what is hypogastrium? So hypogastrium, here you guys can see that this is the hypogastric area, right? Like below the umbilicus and superior to your pubic, right? Area. So this area is basically known as hypogastric region, and iliohypogastric nerve, the sensory innervation, basically it supplies sensory innervation to hypogastric region, right? Is that clear?
Yes, sir.
Okay, so now let's discuss that. For example, if the function of this nerve is compromised, right? If we have compromised function of this nerve, what would happen? We already know. So we'll be seeing deficit of your transverse abdominis muscle and internal oblique. That's obvious. The motor innervation is gone, and the sensory innervation is also gone. So in sensory innervation, we'll be like experiencing some paresthesia, some tingling sensation here in the hypogastric zone. Okay, so now the question arises, like in your USMLE Step 1, you should know that which condition lead to injury of this nerve. That's so important, right? So you guys are already aware of laparoscopic surgery. What do we do in laparoscopic surgery? You know that we have like, small kind of, holes inside your like below the umbilicus here and two holes here in order to cut out and remove your gallbladder. You guys are aware of that, right? So in these cases, for example, if we just give an incision here, a transverse incision here, in order to insert a trocar, trocar is a hollow tube in which like we are gonna do the procedure, cut out your gallbladder and remove here through these small holes, right? So after suturing this transverse incision, so what happens sometimes that sutures can entrap these nerves, and once these nerves are entrapped, you're going to see deficit of these nerves. Is that clear? So one of the condition in which we can see injury or damage of iliohypogastric is laparotomy or laparoscopic surgery. Is that clear?
Yes,
Yes.
doctor.
Okay. And how we discuss the sutures can entrap the nerve, right? Okay. So the motor functions is gone and the sensory. Okay. What was your sensory innervation of this nerve? Burning pain and paresthesia. Where suprapubic area, this area, hypogastric area. It's also, I can just call it as suprapubic. It's like, superior to pubic. Is that clear?
Yes, doctor.
Hello?
Yes.
Okay, so the next nerve which we are going to discuss is genitofemoral. So let's come here and look for this nerve here. You have your genitofemoral. You guys can see from where do genitofemoral arrive? Yes, L1 and L2, lumbar 1 and number 2. Is that clear?
Yes, sir.
Okay, so the next one which we are going to discuss is genitofemoral nerve, right? So genitofemoral comes from L1 and L2. We already know that, right? What's the function of genitofemoral? So as the name indicates, it has something to do with the genitalia and something to do with the femoral part, yeah? or the anterior part or the interior upper thigh, right? Femoral, like for your femur bone indicating your thigh. Is that clear?
Yes, sir. Yes, sir.
Okay, so genitofemoral. So for the genital portion, just remember it's, it's like motor infarction. Like it's going to supply the cremasteric muscle. So what is cremasteric muscle? Are you guys aware of that? The muscle which is basically, which covers your testes, right? You already know that, right? So covering your testes and spermatic cord, you have a muscle which is known as cremasteric muscle, right? And the motor innervation to cremasteric muscle is given by genitofemoral nerve. Is that clear?
Yes, sir.
If you
Yes.
guys remember, we have a reflex which is known as cremasteric reflex. What is cremasteric reflex? Just hit the medial portion of the thigh, and the ipsilateral cremasteric muscle is going to contract, and it's going to move the testicle upward. Simply, that's known as cremasteric reflex, right? What about the femoral component? So remember, the femoral component in the name represent the sensory innervation of this nerve. So it also supplies skin of your, okay, so you have two sensory innervations, right? So like the motor part, we discussed cremasteric. It also supplies sensory innervation to the scrotum, labia, majora, and mons pubis as well. So it have two sensory, right? So in the name genital lies motor plus sensory, right? Motor for your cremasteric muscle and sensory for your scrotum, your labia majora, and mons pubis. Is that clear?
Yes, sir.
Okay, and the femoral part is, purely sensory. So it would supply the skin of upper anterior thigh. Upper anterior thigh skin is basically supplied by this nerve. So for example, if we have deficit or damage or injury to this nerve, what would happen? I would simply say that the cremasteric reflex is going to be absent. Can I say that? Absent cremasteric reflex. If you stroke the inner thigh, you won't see ipsilateral scrotum raise. Is that clear?
Yes.
I would also say that the sensation would also be gone, right? Sensation to the scrotum, labia majora, and mons pubis is also gone. And on the other hand, sensation of your upper thigh is also gone, right? Hello?
Right.
Okay, so how now the question arises that how can this nerve get damaged, right? So an important point which you guys should remember that you guys might be aware of retractor blades, right? For example, if I want to undergo, a surgery of abdomen surgery, so you have retractor blades just like that, right? So with that, basically we pull out, the skin and the muscles in order to have clear view of your abdomen deep down, right? So these retractable blade, if you are just pulling it hard, it can compromise genitofemoral nerve. Is that clear?
Yes.
Okay, so let's discuss our next nerve, that is lateral femoral cutaneous. You guys can see here. Okay, so here's the picture. Lateral femoral cutaneous. From where do we have like from where do this nerve arises? It arises from L2 and L3. You guys can see, right? L2 and L3. Is that clear?
Yes.
Okay, so let's just come down. Okay, so you have your lateral femoral cutaneous. It arises from L2 to L3. We have already seen that, right? As the name indicates, it's purely sensory. Sensory to which area? Name already told you, right? Lateral part of your thigh, and cutaneous means it's purely sensory, right? So it would just run under the inguinal ligament into the thigh, right? And once it, below the inguinal ligament, it reaches the thigh. So it would just supply the lateral femoris for your thigh, right? And only the cutaneous, that is only sensory, right? Hello?
Yes, doctor, right.
Okay. Okay, perfect. So how can we have compromise or injury or compromise or deficit of this nerve? We can have it due to tight clothing, obesity, and pregnancy. So three things. Like for example, if you have an obese individual, he's like having some tight clothing, he's tucking his pants too tight. So what happens? As this nerve is just going below the inguinal ligament, so you can compress upon this nerve, and as a result of that, it would end in a condition which is known as meralgia paresthetica, right? So what is meralgia paresthetica? The region which I have mentioned, which is being supplied by this nerve, you're gonna see some burning sensation, some numbness and tingling, right? Burning sensation, numbness, tingling, and hypoesthesia. Like you won't feel anything there, right? Because due to tight clothing, like in pregnant ladies, it can also compromise the nerve, right? If again she's just doing like having some tight clothing. Is that clear?
Yes, sir.
Okay, so let's discuss our next nerve, that is obturator nerve. So let me just show you the obturator nerve here. Okay, so you have your obturator nerve, right? So obturator nerve basically arises from L2 and L4, right? So you guys can see L4 and L2, right? Okay, so so first of all, you should be aware of the word obturator. What do obturator mean? If you know the word obturator, everything is so simple, right? So obturator nerve. Obturator basically is derived of a Latin word that is known as obturare, right? So obturare mean to close. Okay, close what? For example, if I'm just telling you I want to close my thigh, so can I say that closing of thigh mean adduction? Can I say that?
Yes.
Like for adduction, I can just use a normal or a layman term, that is close your thigh or adduct it, add it to your body, right? Obturator for close and close for adduction, right? Hello?
Yes, sir.
Okay. So adduction basically means that it's gonna supply all of the adductor of your thigh, all of the thigh adductor, and that's so simple. What are your thigh adductor? You don't have to memorize the names, but let me just mention it here. Adductor longus, adductor brevis, adductor magnus, gracilis, right? So all of these adductors are going to be supplied by your obturator nerve, because obturator itself means adduction or to close. Is that clear? So the motor innervation to all of your adductor is basically supplied by the nerve, for that is obturator nerve. Is that clear?
Yes, sir.
Okay, perfect. Okay, so it also have some sensory innervation, as it isn't mentioned here. So some sensory part at the medial thigh, like some of the part is also supplied by obturator. So sensory, a little area at the medial thigh is also supplied by your obturator nerve. Is that clear? Hello?
Yes, sir.
Yes.
Yes.
Okay, so how can we have damage or compromisation or compromised obturator nerve? So for that, you must know the anatomy. How do obturator nerve enters the thigh first, right? So this is gonna be your obturator nerve. You guys can see it here, right? Like this is your obturator nerve. So you guys can see it comes in the pelvis at posterior pelvis and it just came down and there it's gonna supply all of your adductor, right? So, for example, in certain pelvic surgeries, right? In pelvic surgeries, for example, we use, basically we use a device or we use an instrument which is known as trocar. You know what is trocar? We already discussed in laparoscopic surgery. We also use that. So it's a kind of hollow tube right here. Let me just show you the trocar. So it's a kind of hollow tube. Like for example, if we want to do some pelvic surgeries and that trocar is inserted too deep, right, too much deep, so it can injure your obturator nerve, right? So trocar is basically a hollow tube in which different instruments can be inserted. Like for example, you can even insert a camera in which you can just look for the different nerves and different parts of your pelvis. Is that clear? So trocar, whenever it's inserted too deep into the pelvis, it can compromise your obturator nerve, right? And as a result of that, what will we be seeing? We'll be seeing weak adduction, right? Weak adduction, right? And along with
Yes.
that, we are also going to see numbness. That's the small area which I just told you at the medial thigh. So we'll be seeing numbness at medial thigh as well. Is that clear?
Yes.
Okay. So the next nerve which we are going to discuss is femoral nerve, right? Yes, please.
And can you just tell the what's the root of obturator nerve?
Okay, so for the obturator nerve, you don't have to know exact root, but the important thing which you should know that it runs in pelvis, but a little bit deep, right? It lies deep in the pelvis. So if the trocar is inserted too deep in pelvic surgery, you just note down these keywords, right? And whenever you have a U-word MCQ and that in the, Vinny and they're just telling you we are just inserting a trocar in a pelvic surgery too deep, right? So for that, which nerve is going to be compromised? That's obturator, right? Simple.
Yes.
Okay. So like you don't have to memorize the entire anatomy that it's going to run here, there. Like it isn't high yield. You won't see any MCQs on that, right? Okay. So let's discuss our femoral nerve. So first of all, let me just show you the lumbosacral plexus and look for the femoral nerve, right? So here you guys can see your femoral nerve, your big femoral nerve. Okay, so femoral nerve basically arises from L2 and L4. You guys can see it here, right? L2 to L4, right? L2 to L4. You guys can see femoral nerve arises. So as the name indicates, femoral nerve. So what do you guys think? What would be the motor innervation of this nerve? Yes.
Hamstring, isn't it?
Sorry?
It will supply the femoral nerve will go to the thigh, supply the muscles of the thigh.
Okay, perfect.
Yes.
Perfect. If it's femoral, we already discussed stands for like thigh, right? Maybe femur bone, thigh, right? So it means that it would supply the muscle in the anterior compartment of your thigh or your hip, right? Hip and thigh. So can you just tell me some of the flexors of your hip? So all of the hip flexors are basically supplied by your femoral nerve. And what are the hip flexors? Here you guys can see your pectineus, your small pectineus. You don't have to memorize the names, but at least you should know that what's the function of femoral nerve. If you know that it innervates the hip flexors, that's more than enough, right? So what are your hip flexors? Your pectineus is your hip flexor, your iliacus, iliopsoas, right? So this is your psoas muscle and your iliacus. Both of these muscles just combine together and insert here on this on the bone, which leads to flexion, right? So iliopsoas is also supplied by your femoral nerve, which is your hip flexor, and along with that the sartorius. You can simply think of if I'm just pulling both of these muscles. So what would happen? You're going to see hip flexion again, pectineus. I'm just pulling it from its origin side. You're going to see flexion. Again, sartorius. If I'm just pulling sartorius from its origin side, so we'll be seeing flexion of hip. Is that clear?
Yes.
Yes.
Okay, perfect. So femoral nerve, it's also going to supply, anterior muscles of your thigh. What are anterior muscles? Simply known as quadricep muscles. If you remember, important in patellar reflex, right? Femoral nerve is important for your patellar reflex. Remember? Hello?
Yes, sir.
Yes, sir.
Okay. Okay, so you have quadricep muscles. What are quadricep? It means four muscles, right? So here you guys can see you have your rectus femoris, a big rectus femoris, and three vastus muscles. Vastus lateralis, vastus medialis, and below the rectus femoris you have
That's
vastus,
just intermediate.
yes,
Intermediate.
intermedius, right? So intermedius lies below the rectus femoris. So simply you can just think of you have four muscles. Okay, what's the function of them? They basically extend your knee as well. You all of you guys are aware, right? We discussed that the tendon is going to come upon your patellar bone. It's going to be inserted at the tibial tuberosity. Did you guys remember Osgood-Schlatter syndrome? Right? So if I'm just pulling all of these muscles from the origin side, what happens? Can I say that we'll also be seeing extension of the knee? If I'm just pulling it.
Yes.
Hello? So they are also knee extensor. Is that clear?
Yes.
Okay. So let's discuss what's the sensory innervation of femoral nerve, right? So all of it was motor. Motor for hip flexors. We discussed what are your hip flexors, pectineus, iliopsoas, and sartorius. It also supplies the muscles in anterior thigh, femoral. The word femoral refers to thigh, right? So it would supply all of the quadricep muscles, the vastus muscles, and rectus femoris, which also extend your knee. So we already discussed the motor innervations. Let's discuss the sensory innervation. So as the name indicates, it's femoral, right? Again, so it's going to supply all of the medial portion, or the medial thigh is supplied by, okay, a small portion here was for obturator, if you remember, and this was for your lateral, remember? Lateral femoral cutaneous, right? Hello?
Yes.
Okay, and this portion, this sensory portion is basically separated by your femoral nerve, and the small portion was for your obturator. Is that clear?
Yes, sir.
Yes.
Okay, so, and you guys can see here, like it also have a branch which is known as, yes, saphenous nerve, right? So saphenous nerve branches from femoral nerves, and it supplies basically the skin of medial leg and foot, right? So this is also supplied by your femoral nerve via a branch which is known as saphenous branch, right? Saphenous cutaneous branch, which is purely sensory, right? But what's the importance of that? You guys know in a cabbage, we already discussed, like cardiac, like bypass surgeries. Basically, we just take saphenous vein, right? And saphenous vein is in close association with this saphenous nerve. So for example, if someone is just taking saphenous vein for coronary artery bypass surgery, so what happens sometimes, the saphenous nerve is also compromised. And if the saphenous nerve is compromised, we already know the innervation, so you'll be seeing numbness at the lower leg and your foot, the medial aspect. Is that clear? Hello? Hello?
Yes, sir.
Mhm.
Okay, so let's discuss the importance of femoral nerve, right? We already are aware of a reflex, if you guys remember, patellar reflex, right? If you just hit upon the tendon of patella, so what happens? Your knee is you're going to kick, right? You're going to extend your leg, right? Extension, you're going to kick forward, right? And that extension we already discussed, it's done by your quadricep muscles. Is that clear? Hello?
Yes, sir.
And
Yes.
it's a patellar reflex. What is reflex? Reflex don't goes to brain, right? It's present within the spinal cord. Remember, we will be just discussing this in detail in our neurology section.
Yes.
It's a reflex. It happens by itself, right?
انا بس
Oh, can you just
اتواصل
please
معاه
fix your mic, Dr. Shafiq?
قال لي عشان ارسل لك الرساله
Hello.
ايش قال اخر
Hello.
اليوم ان شاء الله قال
Okay.
جزء
Okay. So we have patellar reflex.
Uh,
Sorry.
we could not hear what you said at the last because of the
Hello?
mic issue.
Okay. So we were discussing patellar reflex. Patellar reflex is basically a reflex. Reflex is anything which is present within your, the pathway for that is in the spinal cord. It don't, go to your brain, right? So it is a reflex. If you hit the patella, you just awaken the monster, so it would happen by its own. It have to work by its own. So you don't have to think about the reflex. And it is basically done by your quadricep muscles. Quadricep muscles are supplied by femoral nerve. So for example, if I have a femoral nerve compromised, so what would happen to the reflex? Reflex is lost. You have an afferent pathway and efferent pathway. We'll be discussing that in neurology section, right? So femoral nerve is important for patellar reflex. Those who have like compromised function of femoral nerve, you are going to see absent patellar reflex. Is that clear?
Yes, sir.
Okay.
Yes,
For
sir.
example, if we are undergoing some surgery of your thigh, so what happens? We have to, numb, or we have to, we are going to tell femoral nerve to sleep, please, right? So, for example, if I want to just give some anesthetics, so we are going to, tell the femoral nerve, we are going to inhibit the sensory innervation of femoral nerve. And for that, we have a mnemonic, if you guys remember, naval. You have a UWorld MCQ on that in cardiology section, if you remember. NAVL, right? So for example, if I want to, anesthetize my femoral nerve, so what we are going to do, we are going to palpate your artery, and the lateral side, what we are going to do, we are going to give local anesthesia. Is that clear?
Yes.
Yes. So this was all about your femoral nerve, and we discussed the femoral nerve is also important for your patellar reflex, right? So the next nerve which we'll be discussing is our, which nerve? Sciatic nerve, right? Hello.
Yes,
Yes.
sir.
Okay, so we'll be discussing sciatic nerve, right? Okay, so the entire details of sciatic nerves, I'll be discussing that in our next slide. That is basically going to do with radiculopathy. So we have a lot of signs and symptoms associated with sciatic nerve, but for now we'll be just discussing the distal portion of the sciatic nerve, right? So sciatic nerve is the largest nerve. You guys already know that, right? And if we have posterior dislocation of our femur, it's going to compromise your sciatic nerve. Posterior dislocation, right? Is that clear? For example, if you have your acetabulum, we'll be discussing that, and basically the femur is inserted here in the acetabulum, right? So if we have posterior dislocation, you're going to see compromise of sciatic nerve, right? If the femur goes posteriorly. Is that clear?
Yes.
And you have a UWorld MCQ on that. They're going to ask you simply. Okay. So sciatic nerve basically come from L4 to S3, and it's the largest, it has a width of 2 centimeter, right? So for now, we'll be discussing the distal portion, right? So the medial portion will be discussed in the lecture of radiculopathy, which is going to come right after this lecture, right? So we already know that sciatic nerve gives 2 branches, right? Which branches? Common, peroneal, and tibial, right? So this is going to be your tibial and your common peroneal, right? Common peroneal. Is that clear?
Yes,
Yes.
sir.
So at the level of popliteal fossa, simply you can think of your sciatic nerve is going to give 2 branches, your tibial and common peroneal. Is that clear? So let's discuss common peroneal in a little bit more detail, right? So common peroneal nerve is also known as common fibular nerve, right? It's also known as common fibular nerve. Why? Because it wraps around the head of fibula, right? So it's present like in association or in close association with your fibula. That's why it's known as common fibular nerve. Is that clear?
Yes, sir.
Okay. So the common peroneal is further divided into 2 branches, right? So common peroneal further gives 2 branches, right? One is your superficial fibular, as it is also known as common fibular, right? So superficial fibular and deep fibular. Is that clear?
Yes, sir.
Okay, so let's discuss superficial fibular. Superficial fibular nerve basically supplies the lateral, the lateral compartment of your leg, right? So all of the muscles which are present in the lateral compartment here in the leg, basically the muscular or the motor innervation is given by superficial fibular nerve. Is that clear?
Yes, sir.
Okay. So, okay, let me just ask you a question. For example, if I'm just pulling these muscles from their origin side, so which function or which, movement am I going to see here? Can I say that I'm going to evert my foot? What's evert? Whenever you are just lifting this, like the lateral part of your foot upward, that's simply known as eversion, right?
Yes, sir.
So can I say that these lateral compartment muscles are important for eversion of your foot?
Yes, sir.
Yes.
Okay. So can I say whenever the superficial fibular nerve is compromised, damaged, lacerated, you can't evert your foot?
Yes, sir.
Okay,
Correct.
perfect. Okay, then you have your deep fibular nerve. Deep fibular nerve basically supplies the anterior lower leg muscles, like this portion, right? The anterior lower leg muscles. They are supplied by your deep fibular nerve. For example, again, if I'm just pulling these muscles from their origin side, so which motion am I going to see in the foot? No, the foot is going to move upward. What's the name of that?
Dorsiflexion.
Dorsiflexion. Perfect. Dorsiflexion. Right? So can I say whenever the deep fibular nerve is damaged or compromised, we won't be having dorsiflexion, right?
Yes.
Yeah.
If we do not have dorsiflexion, simply can I say I'll be seeing foot drop?
Yes, sir.
If you can't dorsiflex, it's obvious the opposite muscles are going to dominate and they are going to plantar flex. Plantar flexion is foot drop, right?
Yes, sir.
Okay, so this is one of your U-World MCQ. Whenever we have compromise of common fibular, if you are just you're compromising the deity, right? The dead, so the children aren't going to function, right? So we'll be seeing plantar flexion or foot drop. Is that clear? One of your U-World MCQ.
Yes, sir.
Okay, so dorsiflexion, we won't be seeing. Okay, so what's the sensory innervation of both of these muscles? The common peroneal, they basically supply the dorsum of the foot, right? So all of, okay, let me just show you here. So this was basically your dorsiflexion and your plantar flexion, right? So here you guys can see that the dorsum of the sensory supply to dorsum of your foot is also supplied by your common peroneal nerve. Is that clear?
Yes, sir.
Okay. So, like, how can we have injury of this nerve, right? Question arises. So, the injury, that's so simple. For example, if let's suppose the fibular head get damaged, right? In a trauma, or for example, if you have trauma to like somewhere, in the tibia, let's suppose, and I'm, wrapping and I'm just, like putting a cast to the leg, it can also compromise or impinge the common peroneal, which can give you foot drop. Is that clear?
Yes, sir.
Okay, so let's discuss our next one. That was your tibial nerve, right? Tibial nerve, right? So tibial nerve is going to come, it's going to supply the posterior compartment. That's so simple, right? And if I'm just, like pulling the posterior compartment, so what can I say? I'll be seeing plantar flexion, right? You can
Yes,
see if I'm just pulling these muscles from their origin side. So it's going to push the leg down, plantar flexion, right? So what's the function of tibial nerve? First of all, they're going to supply the posterior leg muscles, right? So like it's also going to, move through this medial malleolus right here. And you have a tunnel here, which is known as tarsal tunnel. So through the tarsal tunnel, basically is going to go and it's going to supply the sensory innervation to heel and sole. So sensory innervation to heel and sole is basically supplied by your tibial nerve. If you guys remember, I just told you that we will be discussing Baker cyst in the future videos. So what was Baker cyst, if you remember? It was cyst in the popliteal fossa, right?
yes, sir.
In continuation with your joint space, if you remember. So this Baker cyst can compromise which nerve? Tibial nerve, one of your U-World MCQ, right? Tibial nerve. So this was the best, topic to discuss, or like the Baker cyst, right? So this was all about tibial nerve and common peroneal nerve, right? So I want someone to revise this entire, discussion. So, okay, only of the branches of your sciatic nerve. Okay, so those who want to just revise, okay, let me select it. Dr. Muskan, hello, are you here?
Yes, doctor.
Okay, so can you just please tell me the branches of your sciatic nerve, the common peroneal and its branches again, what's the function, and again the tibial and everything, please?
Yes, doctor. So we talked about the sciatic now. We know it is the longest now, and
Okay, first question, how can we have damage of the entire sciatic nerve? Which dislocation?
yes, doctor. When there will be, for example, when we wrap around the fibula below the knee.
Okay.
And
Okay.
hip
Posterior dislocation.
posterior hip dislocation. Yes.
Okay, perfect. That was also your UWorld MCQ, right? So today you guys are going to practice 26 MCQs of UWorld, right? So for the first day, for first 2 days, I just kept like 11 and 13 MCQs because like, you know, it's a Ramadan, but today you guys are going to do 26 MCQs. Just be prepared for that as well. And we are finished or we are done with the UWorld and the anatomy portion. So tomorrow we'll be discussing the pathology, right? Okay, yes, Dr. Muskan, please.
Yes, doctor. So I was saying you that about we were talking about the posterior hip dislocation will lead to the injury. Okay.
Okay,
Okay.
perfect.
Then it arises from L4 to S3. Okay. We talked about the distal one. Okay. So distal one, it has two common peroneal and we have the tibial. So the
Perfect.
common peroneal, it has superficial and it has deep. So the superficial one, it's give yes, the superficial one, it will how to the lateral compartment. Okay.
Lateral compartment. Okay, perfect. What's the function of lateral compartment? What's the
Yes.
motor and what's the sensory function? Yes.
So yes. So when in the lateral compartment, there will be the eversion. When there will be the damage, there will be eversion. Like when the muscle will be stretched upwards, there will be eversion. And for the
Okay. And for the deep, it
there will
supplies
be
anterior
dorsiflexion.
compartment, right?
Yes. And
If
for the
I'm just
deep,
pulling the anterior compartment, we'll be seeing which motion dorsiflexion, right?
dorsiflexion. Yes. Foot
Okay,
drop.
perfect. So if yes, foot drop if they are damaged. Perfect. Yes.
Yes. After that, what we talked about, we talked about tibial.
Yes, tibial.
Yes, doctor, about the tibial. So
Okay.
about the tibial, it's gonna supply the posterior leg muscle. Okay.
Okay.
And what more?
Plantar
Yes,
flexion, right?
plantar flexion is its yes function,
Okay.
and inversion. Yes. So yes, the most important point, Baker says it will compromise the tibial nerve. Like
Okay,
it's gonna lead
perfect.
to damage of this. So we will lose this plantar flexion. We will lose this function. Yes, we will lose inversion.
Yes, perfect. Inversion is also done by that, right?
Yes.
Okay. So let's discuss our last nerve, that is pudendal nerve, right?
Sir, one question.
Yes, please.
So, sir, basically, the superficial fibular nerve was supplying the lateral compartment of leg. So, if it is
Yes.
damaged, then it would cause the eversion, right?
If it is damaged, you can't evert. Normally, it causes eversion.
Yes,
Lateral.
normally it causes, yes.
Yes.
And the other one causes normally the dorsiflexion, and the damage would hamper that.
Yes. It
Yes.
normally causes dorsiflexion. If it's damaged, it would just cause wrist drop, plantar flexion, opposite muscles dominated. Is that clear?
Yes.
Okay, thank you. So let's discuss our last nerve, that is pudendal nerve, right? Pudendal nerve. What's the origin? Origin, it comes from S2 to S4, from the sacral plexus, remember, right? So basically the term pudendal mean to be ashamed, right? So it means it's going to supply a certain area which is, you know, like kind of, you know, shameful, or kind of, I would say. So it basically supplies the genital area, right? So the genital area is supplied by your pudendal nerve, right? You guys are already aware, like in the renal section, if you guys remember, we were doing like incontinence, if you guys remember, right? So one of the cause was stress incontinence. It happens whenever we have damage to the pudendal nerve. Levator and eye muscles are compromised. Your world MCQ, are you guys, can you guys recall that MCQs which I am discussing?
Yes.
Yeah.
Okay, so you were having an MCQ on that how can you have stress incontinence, that is whenever a female is coughing, right? So this was one of your UWorld MCQ. Levator and eye muscles basically are, you know, compromised, and we can have incontinence. And another MCQ of UWorld, if you guys remember, which exercises are the first line exercises in order to strengthen the activity of your levator and eye muscles. Remember, what were the name of those exercises? Your UWorld MCQ. Kegel exercises, perfect. Third UWorld MCQ, how can we have compromise of pudendal nerve? You remembered multiple deliveries, remember?
Yes, sir.
So we already know this nerve, right? So basically, it's going to supply the muscles, the levator and eye muscles, like the external urethral sphincter. It acts as that, right? The internal anal sphincter, we already know that. So this is basically your perineal area, and all of the sensory and motor innervations are going to be supplied by this nerve. But third thing, you guys should know that we already know that in multiple vaginal delivery is going to be compromised, which can lead to fecal and urinary incontinence, right? You already know that. So, for example, in like a childbirth or vaginal childbirth surgery, for example, if we want to make it less painful, so which nerve are we going to anesthetize? That is pudendal nerve, right? Hello?
Yes,
Yes,
sir.
right.
For that, you should know a little bit anatomy of this nerve. So this is basically known as your ischial spine, right? So pudendal nerve normally, like, pass through this ischial spine. So if we want to anesthetize this nerve, what we are going to do, we are going to, palpate the spine through the vagina, and what we are going to do, we are going to anesthetize it. So it would lead to less painful childbirth or delivery. Is that clear?
Yes, sir.
So with that, our section of lumbosacral plexus is done, and the next topic which we are going to discuss is lumbar radiculopathy, right? Lumbar radiculopathy. So what is radiculopathy? The term radiculopathy normally means compression of the nerve root of spine. All of these nerves we discussed, they basically comes through our spinal canal like that. Whenever we have, compression of these roots, it lead to radiculopathy, right? Radiculopathy in turn would lead to a lot of symptoms, pain. We'll be discussing that, right? So what can be the causes of radiculopathy? If you have compression of roots, of nerves at their roots, what would be the causes of that? The causes are so simple, herniated disc. This disc, if you remember, you have a UWorld MCQ on that. We have like two areas of this disc, right? The nucleus pulposus and, yes,
And annulus
fibrous.
fibrosus.
Yes, annulus fibrosis. Okay, and nucleus pulposus is remnant of, yes, remnant of what?
Notochord.
Notochord.
Perfect, notochord. Right? So what happens sometimes, you have a ligament, we'll be discussing that is posterior longitudinal ligament. That's a weak ligament. So sometimes, like due to weight bearing activities, that ligament can rupture, and all of the component of this vertebral disc can herniate into the, like into the back, into the spinal canal, and it can compromise the nerve, which can lead to radiculopathy. Is that clear? Spinal stenosis can also do that. What is spinal stenosis? Stenosis refer to, thickening or like, like decreasing the lumen of this spinal canal. So that's basically known as spinal stenosis. We'll be discussing each one, right? And that's spondylolisthesis. What is spondylolisthesis? For example, if one vertebra is, slipped over the other vertebra, it can also compromise the nerve, right? So we'll be discussing each one in detail. So the first one which we are going to discuss is intervertebral disc, right? That is disc herniation. So we already know that it's basically made of like two things, that is annulus fibrosis and nucleus pulposus, right? So it was your annulus fibrosis and your nucleus pulposus. So here you guys can see it's basically herniation of your nucleus pulposus, right? Here in the lumbar spine. Is it clear? This is like the picture of herniation, which you guys can see. It can pinch the nerve, it can compromise the nerve, which is basically known as radiculopathy. So here you guys can see, like, for example, this is your intervertebral disc. I already discussed that we have a ligament here, which is known as posterior longitudinal ligament. It's weak, right? Normally, like if you compare it with anterior longitudinal, it's a kind of weak ligament. So whenever like it ruptures, all of the component can go here in the spinal, this like a canal from which the like nerve is originating, and it can compromise the nerve, which can lead to radiculopathy. Is that clear? Hello?
Yes,
Yes,
sir.
sir.
Okay, the next thing which we discuss is spondylolisthesis. So what is spondylolisthesis? Like, for example, if we have, like, for example, we have like 1 and 2. These are like, let's suppose, our vertebra, right? For example, if this vertebra is slipped over the other, right? So if they are moving like that, if you have slipping of vertebra, so again, if the nerve is coming out here, nerve is going to be compromised, right? It can lead to radiculopathy. Can I say that?
Yes.
Yes.
So spondylolisthesis basically means like slipping of vertebra over one another, right? So it would lead to radiculopathy as well. The third thing which we discuss is spinal stenosis. So what is spinal stenosis? Stenosis means nerving, right? So whenever we have nerving of this canal that is known as spinal canal, so what happens now if the lumen is, nerving, so the nerve which is coming out of this canal is going to be compromised, right?
Yes, sir.
Right? Again,
Yes, sir.
it could lead to radiculopathy, right? So how can that happen? Like, for example, sometimes with age, what happens, the content within the vertebral canal, the vertebral disc, it's going to be like decreasing, right? So if the content is decreasing, what happens? Both of these vertebrae are going to come closer. And with that, what happens? The lumen size is also going to become more narrower. Or on the other hand, for example, this is your ligamentum flavum. If the ligamentum flavum undergo hypertrophy, it can also narrow the spinal canal. Is that right? Hello?
Yes, sir.
If we have narrowing of spinal canal, it can again lead to radiculopathy. Okay, how to look for an individual who is having spinal stenosis? The idea is really clear, right? So in the history, in the variant, whenever you hear, if a person is bending forward, normally if I'm bending forward, what am I doing? I'm increasing the lumen of spinal canal. Normally, remember, right? If I'm just bending normally forward, right? And if I'm just standing like, still straight, so what happens? Normally the lumen is decreased, the lumen size is decreased. So for example, if a person is having stenosis and he's bending forward, so what do you think what will happen to the symptoms? Symptoms would decrease, right? Because you are giving more space for the nerves, right?
Yes.
So in the
Yes.
question, whenever you see that the bending improves the pain, obviously you are going to experience some pain. So you guys can see like what happened in stenosis. Let's suppose if there is osteoarthritis, osteoarthritis leads to bone spurs and it can narrow the lumen. And this individual, if is bending forward and the symptoms are improved, simply it means that he has spinal stenosis, right?
Yes.
Is that clear? Okay. So, like this was the entire discussion. For example, if the ligamentum flavum, hypertrophied or, the intervertebral disc decreases, so it can lead to spinal stenosis, right? So we were discussing, I was just telling you, we'll be discussing sciatic nerve, the proximal portion, right? So this is the best place where we can discuss the proximal, because spinal stenosis can also lead to a condition which is known as sciatica, right? So we discussed that sciatic nerve is like the largest nerve. And what's the motor innervation here? That's obvious, the posterior thigh, right?
Yes.
The posterior thigh is basically innervated by sciatic nerve. Okay, what are the muscles present? The main muscles are hamstring muscles, right? And some
Yes.
of the adductor muscles. So the hamstring muscle. Okay, what's the function of hamstring muscles? Can you guys just tell me?
It's hip extension and knee flexion.
Perfect. That's hip extension and knee flexion. So whenever we have compromise of sciatic nerve, you can't extend your hip or flex your knee. Is that clear? So knee flexion, hip extension, and hip rotation as well. Hip rotation is also going to be compromised, right? So we are going to discuss a condition that is known as sciatica. So what is sciatica? It's basically a syndrome in which, like, for example, due to certain radiculopathy, sciatic nerve is so big. So we have a lot of branches or a lot of spinal nerves contributing in formation of this nerve, like L1. You guys can see this is your sciatic, right? L5, first sacral, second sacral, third, all of them contribute in formation of sciatic nerve. But an important and high yield, what's the most common cause of sciatica due to radiculopathy? If it's radiculopathy, it means that one of the component is going to be, one of the component or one of the spinal nerve is going to be compromised. So the most common is L5, remember, right? Number 5 is the most common one. Is that clear? Hello?
Yes, clear, sir.
Okay. So like how can lumbar 5 be compromised? We already know the causes. For example, if the disc herniate and it compromises lumbar 5, you can have problems in the sciatic nerve as well, because L5 contribute in formation of sciatic nerve. That's so simple, right? Simply, if, for example, if we have stenosis of L5, so it's the most common one, right? Present here due to like weight-bearing exercises. So L5 is the most common one, right? And the first sacral is the second most common one, right? So And the other thing, for example, if I need the entire compromise of this nerve, right? So one we discuss, it can be due to radiculopathy. That is for L5 on the first and first cycle on the second number, right? But how can we have compromise of the entire sciatic nerve? The idea is very simple. If we have hip fracture, right, or dislocation, posterior dislocation, an entire rupture can lead to, problems with this nerve. Is that clear?
Yes.
Okay, so now question arises that, for example, if we have like fifth lumbar compromise due to radiculopathy, or it's due to like herniation, so what would be the signs and the symptoms which will be seen? So for L5, remember, individual is going to lose, yes, dorsiflexion. Dorsiflexion. Remember, dorsiflexion was for your, remember, anterior thigh. Okay,
Deep.
sorry, anterior leg, deep, fibular, right? So remember, for the L5, we are going to experience pain at the lateral leg, right? Lateral leg. So L5, L for the, L5 and L for lateral leg and dorsiflexion. Just keep that in mind. Very important, right? So in the variant, whenever you see like we have an individual, he has spinal stenosis, and now he cannot dorsiflex his foot. On the other hand, he's having pain at the lateral leg. So which component of sciatic nerve is compromised? That's L5. Is that clear?
Yes, sir.
Yes, sir.
Okay. Okay. Perfect. Right. So, for example, if you are just suspecting someone of having sciatic nerve compromise, like for example, whenever we have sciatica, so the pain is going to be like along the root of this nerve, right? So it's going to be like moving along the root of this nerve. So for that, we are going to do an maneuver, which is a bedside maneuver for lumbar radiculopathy. What's that? We are going to tell an individual to lie flat, and we'll just, for example, if he's experiencing pain in this leg, and you are just suspecting of lumbar radiculopathy, so we are going to raise the legs, and if he is having stenosis, if he is having radiculopathy, the pain is going to be worsened, right? And that worsening pain is known as Lasik sign, right? Lasik sign. Is that clear?
Can you
Which
repeat,
basically,
please?
okay. For example, if you have an individual and you are just suspecting of lumbar radiculopathy, right? It can be due to stenosis. It can be due to herniated disc. Is that clear? So which maneuver we are going to do? We are going to tell this individual to lie flat and raise his leg, right? So raising of the leg, simply you can think of, you are just narrowing the spinal canal by raising the leg, right?
Yes.
If you're just narrowing the spinal canal, and if already this person is having, like radiculopathy, already the canal is too small, and you're further, decreasing the lumen of that canal. So already, that's obvious he'll be experiencing pain with that, right? If he have radiculopathy.
Yes,
Yes.
And if he experience pain, we are going to say that the Lasik sign is positive. Is that clear?
Yes.
Okay, perfect. So the last topic of today's discussion, and with that anatomy is finished, is hip joint, right? Hip joint, right? So we are already aware of the joint, like you have acetabulum and basically, the insertion of the femur head in the acetabulum. It's an example of ball and socket joint. If we have ball and socket joint, we can do a lot of movement: abduction, adduction, flexion, extension, and rotations. Is that clear? We already did that in our hand. That was an example of our shoulder joint, right? That was an example of ball and socket, remember? So in the ball and socket kind of joint, we expect a lot of movements. Is that clear?
Yes, sir.
Okay, so let's discuss some of our major flexors. We already discussed flexors. Okay, what's the nervous supply of your hip flexors? First of all, we already discussed that. Which nerve?
Femoral.
Femoral nerve, perfect. And what were your hip flexors we discussed? Pectineus, iliopsoas, right? Sartorius, remember? All of them are your hip flexors.
flexor.
What about hip?
Quad.
Hello? Can you guys hear me? Hello?
Yes, sir, we're here.
Okay, so We discuss about Dr. Mosab. Can you just please fix your mic? There is some disturbance, please. Okay, thank you. So let's discuss hip extensor. So you have our muscle, which is known as gluteus maximus. No, gluteus maximus. It's your major hip extensor, right? Your hamstring. We discussed hamstring muscles, right? Okay, what are your hamstring muscles? You don't have to memorize, but let me just tell you your semimembranosus, semitendinosus, biceps femoris, right? But the hamstring are your major hip extensor. You already did that, right? Then your abductor. Let's discuss some hip abductor. What are your abductor? Okay, this is your abduction, right? The exercise basically normally we do in the gym, right? So your gluteus medius and your gluteus minimus basically are your major hip abductor. Is that clear?
Yes, sir.
Okay, major hip adductor. We already know the adductors. Adductor magnus, remembered? Obturator nerve. How can you forget that? Hello. Closing you
Yes, sir.
eye. Okay, obturator. Adductor longus, brevis, and magnus. Okay. What about external rotation? How can we have external rotation of your hip? So external rotation is basically, like done by a small group of muscles, obturator, internus. You don't have to memorize it, by the way, but gluteus maximus also helps in a little bit external rotation. Remember, right? Gluteus maximus is also important for external rotation. We have a small group of muscles like gemellus, superior, inferior. You don't have to memorize it, right? Superior, inferior, there are also some external rotators. Don't worry about that. I think that isn't how you do want to, like get asked by the USMLE. Don't worry about that. Then you have your internal rotator. You do not have primary internal rotator, so that isn't high, right? So a group of muscles also tends to internally rotate your hip joint, and those group of muscles, the pectineus does that. Whenever all of them are activated, then we are going to see internal rotation, right? But an important point which you guys should remember is the nervous supply. So we have superior gluteal nerve. Superior gluteal nerve is going to supply your, yes, gluteus minimus and medius, which was your abductor. Remember? Hello? Hello?
Yes, sir.
Okay, so superior gluteal nerve basically supplies your gluteus minimus and medius, right? An important point, your U-World MCQ, for example, if you want to, let's suppose if you want to give some intramuscular injection in the buttocks, right? So which region are we going to inject? Remember, in this region of the buttock, basically your sciatic nerve runs, right? While on the upper medial portion, basically, this superior gluteal nerve goes and it innervates your gluteus minimus and medius, right? So this is the safe place where you can just undergo the intramuscular injection. But in the U-World, you will be having an MCQ. They'll be telling you that we have an inexperienced nurse. He injects somewhere here in the medial side, right? So in the medial side, which nerve is going to be compromised? Superior gluteal. We already know that, right?
Yes, sir.
Right? If superior gluteal is compromised, it means now we'll be having weak abduction, right? Is that
Yes, sir.
clear? Weak abduction is going to end in a sign which is known as Trendelenburg sign. What is Trendelenburg sign? If this individual is, like running, if he's walking, so what happens? You'll be seeing like tilting of hip, right? So the hip or the pelvis bone is going to be tilted, right? Or like for example, if he have nerve compromise on this side, right? So for example, if he's just stepping on this foot, which is if he's just bearing all of the weight during walking on this foot, and he have compromise of the superior gluteal nerve, so what happens? His pelvic bone would tilt like that, right, to this side. So this is basically known as Trendelenburg sign. Is that clear?
Yes, sir.
Okay. So let's discuss our last topic, that is avascular necrosis. So you have a lot of U-World MCQ on that as well. What is avascular? Okay, just give me a second. Avascular necrosis. So avascular basically stands for like no blood, right? So whenever we have compromised blood to the head of femur, it can undergo necrosis. If you aren't supplying, if you aren't giving blood, nutrients, so the head of the femur is going to undergo necrosis. That's obvious, right? So basically, we know that what's the blood supply of the head? We know that we have common. That is common femoral artery. We have branches of common femoral artery that is known as profunda. Profunda is going to give medial circumflex arteries, right? And the circumflex artery is like it's going to encircle the head of your femur and ultimately is going to supply blood to the head. So whenever we have, let's suppose, fracture, it can lead to avascular necrosis. Is that clear?
Yes, sir.
One of an important cause which you guys should know is steroid intake, right? So the exact mechanism is unknown. You are going to see word MCQ an individual who is on steroid, like maybe he's having some autoimmune diseases, and for that he's just using a lot of steroids, glucocorticoids in order to suppress immunity. It also can, it also can undergo, this individual can undergo avascular necrosis of head of your femur. Is that clear? Steroid therapy.
Yes, sir.
Okay, so this was all about today's lecture, and with this we have done like almost entire anatomy. Hope so you guys enjoyed the lecture, and today you have 26 MCQ to do. And another thing which I want to mention is that soon we'll be having a webinar on our research. We'll be just introducing you to our to your mentors who will be helping you. And as I have already mentioned that first of all, we are going to do our research on like a meta-analysis, right? And because it's like considered to be like, more good there. Okay, yes, any questions?
Yeah,
Yes,
I'm
please.
sorry to take you back. Can we please go over the last 2 points you made? The steroids and then the artery.
Okay, so we
Yeah.
were discussing about avascular necrosis. So avascular necrosis basically means whenever avascular mean no blood supply. So whenever like the blood supply to the head of femur is compromised, it would undergo necrosis. It would be died. Simple, right? So we can have like avascular necrosis. Like there are a lot of causes, like direct fracture. For example, if you have direct fracture here, the medial circumflex arteries, which basically supply the head of femur, is going to tear. Let's suppose, right? And if the blood vessels are teared, it means your head cannot have enough nutrients. It would undergo necrosis. And the second one is steroid therapy. The exact mechanism for steroid therapy is unknown, right? No one knows that why do we have avascular necrosis due to steroid therapy, right? But it's very high yield. We are going to have a lot of MCQ in U world. That we have an individual, he's on like he's having some autoimmune disease, he's on steroid therapy. So like what are you going to suspect in this individual? So necrosis of the head of femur should be in your mind, right? It can cause that. Is it clear? Hello?
Yes, thank you.
Okay. Thank you so much, and see you tomorrow. And I'm just sharing task in a while, like 10 to 15 minutes. For that much time, you can just have a break, and I'll be waiting on the Discord server, and you guys can just come there and do your task for today, right? Thank you so much. Thank you. Have a nice day. Bye bye.
Thank you, Doc. Thank you.
Thank you.